It's 11:11. Make a wish.
Total
He's
like, oh my fan girl.
Welcome to a special episode of the Hacking Hypermobility podcast.
I'm Luna.
And I'm Shelli.
And we're two bendy mamas.
Hacking Hypermobility.
And our producer, Tiffany, is going to get us started.
On today's episode, we have a special guest, Jeannie Di Bon. Jeannie is a movement therapist and founder of the Zebra Club, an app that supports people living with EDS and chronic pain. She has EDS, POTS, MCAS, and CFS. Through her lived experience, plus years of clinical experience, Jeannie developed the IMM, a pioneering approach combining neuroscience, biomechanics, movement, and mindfulness. She is the author of the book, Hypermobility Without Tears, and a new book is due out later this year. She is passionate about education, advocacy, and community. Jeannie helps spread education and awareness to both patients and medical professionals by sharing her expertise on her YouTube channel, the Zebra Club app, with her work with the EDS ECHO program, and she's also a frequent presenter at the EDS Society's Global Learning Conferences.
So, Jeannie, we had the opportunity to meet last summer at the EDS Society's Global Learning Conference in Philadelphia. I was a complete fangirl because you were the first person outside of my PT who said, hey, you're hypermobile, that I found as a resource. You disarmed my nerves immediately, though. You taught last year a movement class with Dr. Wang that incorporated movement and breath work. And those were things that I had been working on, but this was truly more helpful than anything I had experienced to that point. And I want to tell you that you've been indirectly helping me personally for 7 or 8 years now, because when I was first told I had hypermobility, I didn't know about EDS. I sought care for my hip issues, and my PT was the first person to say, hey, you have hypermobility. And so I'm searching and researching, and your videos are the first good resource that I found. So you were one of the first tools I had to start holding it all together. It's really exciting for me to get a chance to say thank you, one, and then meet with us. So thank you so much for coming on and having a conversation with the podcast. We have some questions, of course, from us we would love to ask you personally. And then at the end, we have some listener questions from physical medicine providers also. And before we get started, my first question is, how do you prepare for things like this? Do you want to walk us through a little centering activity?
Yeah, we can do that. We can definitely do that. We can take a couple of minutes just to settle. But first, before we do that, I just want to say thank you for that lovely introduction there. And I'm so glad you found me on YouTube and my videos were helpful to you. Yeah, the YouTube continues to grow. I try and upload content to that every week. But no, thank you so much. And yes, it was wonderful meeting you at the conference last year. And yeah, you mentioned Dr. Wang. I mean, those movement sessions we did at the conference were just phenomenal, right?
Even people who weren't hypermobile that were in attendance, like providers and stuff, we all collectively felt that.
Yeah, it was beautiful because we start to, talk about the breath and talk about that relationship with our fascia, with our connective tissue. And it's a really embodied experience. And we can do a little, 60 seconds. Let's just settle in and prepare for the questions and clear our minds. Yeah. So, and of course, anyone listening can do the same at home, which is great.
As long as you're not driving.
Exactly. As long as you're not driving, of course, or operating any kind of machinery. But yes, if you're sitting or lying down, if you're listening to this, if you are happy and safe to do so, go ahead and just close your eyes very softly for a moment and just let your eyes close. And all we're going to do, we're not going to spend too long, but just take a moment to just allow your body to settle into your chair, into your bed, wherever it is that you happen to be listening to this. And what do I mean by that? By settling, I mean just bring attention to your physical body touching the surface, whether that's your pelvis on the chair, whether it's your whole body lying down. just take a moment to feel that and just get a sense of the weight of it. And I find this particularly helpful because I spend a lot of time sitting at my desk. When I have to sit for any length of time, I'm connecting with the weight of my pelvis and I'm letting it settle into my chair. Now, when your pelvis settles and starts to feel a little bit heavier, that allows the breath to be a little bit freer. Because many of us with EDS, we hold a lot of tension up in our chest. Yeah, and we'll probably talk about the breath maybe later. A lot of us have breathing pattern disorders, and we hold a lot of tension up in our shoulders, our necks, our chests. So when you let the weight go into the pelvis, all of a sudden the shoulders, the lungs, they can just drop a little bit, and it allows that tissue to relax. So if that might not happen today, and that's fine. You might need to practice this. But if you can feel your pelvis on the bed or the chair, just now, very, very softly, with hardly any effort, take 2 or 3 breaths in your own time. Don't force it, just very softly, 2 or 3 breaths, and just feel it. Don't try and control it. Just feel it coming in and feel it leaving, whilst maintaining the heaviness of the pelvis. So oftentimes we start to breathe and then we instantly go back to lifting our chests up. So can you breathe with the weight still in your pelvis? And again, that might take practice, and that's fine. And hopefully that's just settled us a little bit. How are we doing with that?
Thank you.
A regulated zebra is a calmed zebra.
Exactly. And, absolutely. A lot of what I do through the YouTube channel, through the Zebra Club with my clients is very much about creating safety and nervous system regulation before we even think about exercise and doing other activities. Because it is so important, because so many of us are coming from a place of dysregulation and anxiety and stress for a number of reasons, right? So it's really, really important. We can't exercise and get stronger with the nervous system that's really heightened and ramped up.
No, and I think we need to regulate, not just for our nervous system to regulate to do body work like exercise, but also at various moments throughout our day before we use our mental and emotional power to sit down and have a conversation, or to face conflict, or to have a good work day, or to be creative and joyful and enjoy the good days. So there's many ways we want to apply this, like today.
Absolutely.
Thank you for starting.
Yes, thank you for that, because
Clearing the space, clearing the figurative room here.
Good,
so we can have a great conversation with you. So let's get started with some questions. Can you share about your personal diagnosis journey and how that experience changed your approach to movement therapy and your career and that sort of thing?
Yeah. I mean, like many of us, my work was coming from a personal story, I guess, and many people get into this kind of work because of their own personal experiences. I mean, it took me 35 years to get my diagnosis, my official diagnosis. So I only got my diagnosis when I was 48. So my symptoms started when I was about 12, 13. So like many people, I had a long journey of seeing lots of people and trying to get answers and going round and round in circles and not getting anywhere. So I was already working with the EDS community before I got my diagnosis. It's strange, isn't it? I mean, I worked with a physiotherapist many years ago who happened to have quite a lot of hypermobile patients. And she started sending me her hypermobile patients. And the more I worked with them, I was like, oh, this is familiar. This sounds familiar. I know. Yeah, this sounds like me. I've got all of those symptoms. So I kind of had this in the back of my mind that perhaps I also had something going on because I was ticking all the boxes. And, my business grew, and it grew so much that I was now only seeing EDS patients sort of on Zoom after the pandemic. Obviously, Zoom allowed me to start seeing people all over the world. And around 2017, I had quite a personal trauma. My mum got quite sick very sick, and she passed away very quickly. And the stress of that was enough to, and we know stress impacts our condition quite a lot. It triggered a really, really bad, what I now know is mast cell activation. I was really, really unwell, and I was looking for answers for a good 18 months, and I was getting sicker and sicker. And eventually I saw a specialist who, thankfully for me, knew what MCAS was, mast cell activation, and knew what EDS was. And he diagnosed me. Yeah, I didn't go looking for an EDS diagnosis.
You were just looking for like, what is this?
What is this? I was really, really unwell. I was having, and at the same time, I was going through what I now know as perimenopause, which of course also impacts our bodies, all those hormonal changes. So I had a double whammy of trauma and stress related to my mother, coupled with the menopause, coupled with existing undiagnosed EDS. And it was like a perfect storm, shall we say. So I was quite distressed when I finally got help. But he was so lovely. And, he explained to me, you've got this thing called mast cells. And he gave me medication that actually started working and relieving my symptoms. And he also just casually said, oh, and you've got this thing called hypermobile EDS. Didn't really explain what it was, but I was like, okay, I know what that is. I don't need it. I know how to look after this. But yeah, that was that. So that was in 2018, late 2018. I finally got my diagnosis. But I was already, working with so many people at that stage. But it all kind of made sense. And I firmly believe that you kind of get sent the people you're supposed to be working with, right? Why did I get sent these people in the first place? And I think it's, I understood them. I understood them from day one when I started working with hypermobile. I just got it. And I, as well as just getting it, I was fascinated by it. I was like, how can there be this condition that affects every system in the body? This is just fascinating. As a therapist, I was like, wow, what can I do to help these people? And it just grew from there. So yeah.
As you developed professionally, you developed your own approach.
Yes.
Tell us about your movement method.
Yes. So the integral movement method, or the IMM, originally, because my background was Pilates, as you read out in the...
There's a reformer behind this curtain.
Is there? Oh, I've got my reformer here.
It's eventually, it will be in the shot, but it's
Lovely. Reformer is a brilliant piece of equipment for hypermobile bodies, if used correctly, of course. You need to know what you're doing on them, as with any piece of equipment, of course. So yeah, because one of my symptoms I'd had from an early, from childhood was pain. I had chronic pain. So I had back pain and shoulder pain and neck pain and pretty much everything. So my initial sort of Pilates career and biomechanics training was working with people with chronic pain. And of course, with EDS, chronic pain is one of the first symptoms that shows itself anyway. So my experience was very much in chronic pain. And I developed the IMM to help get myself out of pain because I was in a lot of pain. So I started working. I noticed that whenever I tried to exercise and go to, classes, I would be in more pain. I would have these things that I now know are flare-ups, and I would be in bed for 2 days, absolutely exhausted. And I was like, something's not right. So I noticed that when I did the breath work and I started, working on meditation, I trained in meditation practices, and I started doing mindfulness and relaxation techniques. I was able to tolerate exercise better. So I realized that I had to calm my nervous system down before I even thought about jumping on a reformer or picking up some hand weights or whatever it might be that I wanted to do. So I started developing this, and then I worked on sort of proprioception and stability, and then working through balance and posture. That's how it kind of evolved into working with the hypermobile population, because obviously proprioception is a big issue, stability is a big issue. And then it was a very gradual process of how can I then bring people up into a standing position and work on balance. So, and then posture emerges from all the other work that you do before. So I believe that posture can't be taught, as in you can't fix someone's posture, stand up tall, pull your shoulders back, suck your tummy in. That's just going to put more tension in a body that's already anxious and stressed. So posture kind of is a natural evolution, and that's why it's integral movement method, because everything becomes integrated through the fascia as well. I talk a lot about fascia and keeping the fascia healthy. So yeah, it was a very organic kind of development of the IMM for hypermobility that really started in chronic pain. And then I was like, well, what do hypermobile bodies need? And then it kind of evolved from there. So yeah, and now that's what I teach through the Zebra Club with my clients. We follow these principles, and it's what I educate through the EDS Society. The ECHO program is the practitioners who come on the training course. We go through those 6 principles in real detail, and we make it practical as well. So it's like, well, how do I teach someone proprioception? How do I teach someone stability safely? We go through all of that. So they've got a program that they can take away and start working with their own patients immediately. So yeah, we're about to enter our 7th cohort of that training course, which is fabulous.
That's so amazing that now 7 groups of providers that treat patients like us are now learning this method. It sounds like you're combining 2 worlds. So, I've met with a health behavioral psychologist that was training in like mental health methods of body safety. Mm-hmm. And then you have to go see a movement specialist or a physical medicine provider or physical therapist, occupational therapist to learn the body exercises. So it sounds like you're really truly doing more integrative, holistic type of practices for us. And I remember your first book, Hypermobility Without Tears, was one of my other first resources. And that's when I started thinking about, okay, I need to address maybe my nervous system things first before I can even get to my neck instability.
While I never gave my nervous system a thought at all, ever, until like 2 years ago.
But I think I only had context for it too because I had read like about polyvagal theory and stuff like that. So I kind of knew that I needed to get in that what they call safe and social state to even be able to perform physically or otherwise. So when is your follow-up book coming out?
So yes, the follow-up book. So Hypermobility Without Tears was in 2019, and then it's been 6 years. So by the end of this year, the 3rd book will be coming out, and obviously things have evolved as well since then. This new book is for practitioners as well as patients. It includes the research study that was actually done on the IMM, the Integral Movement Method, which we conducted with Dr. Leslie Russick, who you may have heard of, a physical therapist in the United States, and Dr. Jane Simmons here in the UK. So not only was the IMM pioneering in that it really was the first method to actually, as you say, look at nervous system regulation. We've known for years and years, you go back and look at books and literature, we know that people had breathing pattern disorders in this population. We knew that, but nobody said, well, what do we do about it? There's a problem here. What do we do about it? It was never addressed in any kind of exercise or physical therapy that you would first calm your system and learn how to breathe again. So the IMM really changed that approach to how do we actually work with our patients so we get better outcomes. So it was pioneering in that sense, and it is now the first exercise method that's actually evidence-based and researched. So we now have a qualitative paper, which was published this year, and we're just finishing off the quantitative paper, which should be coming out hopefully this year. We're just finishing that one off. So at last, we're going to have something that we can say this works because we've got the evidence now. Today, and I think it's shocking, but today, as of today, there are no physiotherapy or physical therapy guidelines for this population. There are no official exercise guidelines for this population. There's nothing. And then we wonder why people don't know how to exercise. They don't know what to do. They're stressed about
Start running when they're 33.
Yeah. And, and we go to PTs or physiotherapists and people don't know how to work with us because it's like, well, why aren't you getting better? You've had 6 sessions. You should be rehabbed by now. You should be better. No, our bodies don't work like that. So I'm really hoping that this new book will give practitioners a sort of a roadmap to say, okay, I've got this EDS patient. What do I do with them? How can I get them feeling better, getting more stable, actually getting stronger? So that's my hope for the book. And I've got 2 lovely guests who have written chapters in the book. I'm not going to say who they are at the moment, but we've got two guests who have written a couple of chapters in there as well. So yeah, very, very honored that they wrote in the chapter 2 chapters for me as well.
But we are so excited to read the book and the guest chapters.
Yeah.
I'm going to let Shelli ask some more like specific questions about our lived experience now.
Yeah.
Yes.
So I mentioned a few minutes ago, I've never thought about my nervous system until I was kind of forced to. And so that leads me to kind of bring up like flare-ups related to heads, and the associated conditions can be unpredictable. So are there any strategies that you can recommend to help you identify a trigger like beforehand to help maybe manage it before you get to where you're frazzled?
Yeah.
Like, yeah, in a really bad flare, stuck in bed,
Yeah. And I'm sure we've all been there, right? As I say, I used to, I've been there, ended up in bed for days. And so, yeah, it's very individual, isn't it? Because we're all so very different. So to avoid exercise and movement flares, I think it's really, nervous system calming, absolutely. We've got to do that first, because if your nervous system is happy, there's going to be less chance of you annoying it and causing a flare up. So we say if everything you try exercise-wise causes a flare-up, so you might think, I don't understand it. I've done the smallest amount of exercise. Why am I in pain? If that's happening to you, your system is still highly regulated. So we need to go back and spend more time doing breath and relaxation. So that's the first point. Okay. The second point is I talk a lot about tissue tolerance. And that's not, tissue tolerance often relates to weightlifting and how much how much load you can take when you're weightlifting and things like that. I don't mean it in that sense. When I talk about tissue tolerance for hypermobility, I mean, what's the minimum amount I can do today that doesn't cause me any pain, fatigue, flare up? Now that might be 1 repetition. So I always say to people, we have to find your tissue tolerance. So your tissue tolerance is going to be different to mine. Yeah, I might be able to do 6 repetitions of an exercise and be absolutely fine. You might be able to do 1 or 2, which is fine. But the problem, again, we're talking about, prescriptive exercise. Oftentimes we're said, you've got to go and do 3 sets of 10, 3 times a day to get better. Yeah. That's too much for us. Because if I said to you, okay, if I go away and do these exercises, I want you to do 3 sets of 10. And you come back to me the next day and say, oh, Jeannie, I'm in absolute agony. I tried to do those exercises and I'm in agony. How do we know what your tissue tolerance was? Because you've done 30 repetitions, right? Your tissue tolerance might have been 2, but I asked you to do 30. So we'll never know because we've gone too far. So my motto is go low, go slow. So we'll start you at 1 or 2 reps. And if you come back and say, oh, that was fine, that was easy, no problems, I'll say, okay, let's add 1 rep. And you do 3 repetitions for the next 2 weeks. And if nothing happens, you can go up to 4. And then you can go up to 5. But you have to test it out. Because there's a lot of times we don't test things out and we just jump up, oh, that's fine. I'm going to go and I've done it myself. This feels really good. I know I'm going to do double the amount that I did yesterday. And your body goes, what is going on? I can't do that.
Why did you run a half marathon?
Yeah. For us, it's a bit like that. It's a bit like, why did you run a half marathon? I was only just walking around the block and you've made me run a half marathon. So we can't do these big increases. Our path has to be so gentle like this. And of course, this same path might have bumps in it. It's never a smooth ride with EDS. There are going to be steps backwards and steps forward and sideways, and that's fine. I think a lot of the flare-up stuff also is, accepting that it's going to be a slow but consistent journey. Little and often is much, much better than doing 3 sets of 10, having a massive crash, and then you've got to wait a couple of weeks before you feel well enough to do it again. So tiny, tiny steps.
So this progressive gentleness into more movement is also teaching us to feel our body's safety.
Absolutely.
I think that's the key. We have many of us have some processing challenges where we don't understand our body cues.
Yeah.
So things I've learned, I need physical cues for everything. Like I have to watch what I'm doing, because if body will just go wherever. This next question ties into the breath work and the nervous system. And I catch myself doing this all the time. So how does the nervous system and the breath work influence movement patterns? Because in Pilates class, because I do work here and I go to a studio too, which is why I know what to do here. And she'll remind us too, because I think she knows some of us do this. Like we do all this breath stuff in the beginning, and I will catch myself if I'm trying to balance or whatever. I hold my breath.
Yeah. Absolutely.
Do you see patterns like that? And how do you get a person to stop doing that, other than just gentle? Is it just gentle, constant gentle practice, I guess?
Yeah.
What else?
I mean, totally. It's totally common. Of course, when you're trying to balance or do something tricky, you're going to be so focused on that. We forget to breathe, right? So we end up holding our breath. And I think, that's where the integral movement method comes from, is that the breath comes first. So I always say the breath is a thermometer. So the breath will tell you how you're feeling. So if you're stressed and anxious, chances are you're going to be breathing up here. Yeah, a little bit shallow. If I'm relaxed, my shoulders can drop, my belly's going to move and expand with my breath, much more relaxed. We want that type of breathing when we move on to do more challenging things. Yeah. So working on the breath, really feeling that breath, and then creating a state where I talk a lot about sensations. Yeah. If you watch any of my videos, I'm always going on, and a bit like we did at the beginning, can you feel your pelvis? Can you feel it? What does it feel like? If we can start to feel sensation, so if I was working with you and we spent some time and I was saying to you, how does the breath make you feel? Do you notice that you've started holding your tension up here again? And then you'll go, oh yeah. Yeah, can you let that go? So we give you cues, like you say, constant little drip feeds. And I'm always asking questions. Can you notice that? Did you notice that? Because then your brain's going, oh yeah, I did notice that. I did notice that.
That keeps my brain wandering.
Yes.
It will go off into, that's why I'm very auditory.
Yeah. So we bring you back to sensation. So we've done that. You've felt your breath. You get a sense of what it feels like to actually have calm and relaxation, right? So by the time you come up to standing, I want you to have that in you already. So when I come up to stand, I'm still feeling that same sensation. Because you've got one nervous system, right? You've got one nervous system. So if we can train it when you're lying down on your back, feeling safe and happy and supported, that one nervous system can be trained to have the same response when you're standing up. It's not a different body. It's not a different person. It's about sensation. How do you feel when you stand up?
Yeah. And I've noticed, so I had started a breathwork practice, and I've noticed, or as I started to feel more sensations, because I really truly wasn't feeling my breath among many things. I noticed, now I can tell that my diaphragm is hypermobile. So like when I stand up, it sinks more. So I have to adjust more if I'm standing or moving. because that's how my organs are.
Wait a minute. Is that why sometimes I stand up and get the hiccups?
Possibly, yes. You got that dysregulation going on inside.
And I learned like, oh, I don't think any of us are using our diaphragm correctly or typically,
Mhm.
you know? And so I learned as I was strengthening that, I had to strengthen that tissue.
Yeah.
And I learned to start doing my breath work. There was a practice where I learned you do your breath work leaned over, and it kind of pushed my diaphragm to get stronger. And at that point, that was when I started to learn how to be able to breathe upright, like standing.
Yes.
Was when I realized, oh, this is weak also. So
That's
it's
a
really
very good
interesting
point.
that you've created the IMM and the method to teach us how to integrate all of these things. But then you also saw a need and you realized, okay, I need to teach all these providers, but how are we reaching these patients and these hypermobile people in the current time? And I want to talk about the Zebra Club app. But before we do that, this room of zebras is in touch with our body right now, like you taught us at the beginning, and we all need to stand up.
Jeannie, can you tell us more about the Zebra Club app? I know that it's pretty new and I'm very intrigued by it. What motivated you to create the Zebra Club, and how does it serve the hypermobile community?
Yes, thank you. Yeah, the Zebra Club is sort of my life's passion. It came about, I mentioned earlier that we did this research study with Dr. Russick into the IMM. And that research study was based on my very first online course back in 2016 for hypermobile people. It was called Strengthen Your Hypermobile Core. And it was 5 lessons of 30 minutes long. And we decided to do a research study on that program to see if it actually did make a difference. Was it working for hypermobile people? And that's the paper that's just been published. Through that research study, we had over 600 people register. So it was a big study. We learned I learned. There was Through that research study, I learned an awful lot about what the community needed. You know, for example, it was this initial course was one course, it was one level. You know, there were no different levels, there were no accommodations. It was, you do these 5 lessons and that was the course. So the Zebra Club really took that feedback and said, how can we develop this further? And which is what I did. So I created a community. You know, people, a lot of our community are at home or they didn't know people who had EDS. So there was a sense of isolation. So community was really, really important. So the Zebra Club has 3 main pillars: community, movement, and education. So we have probably 200 classes on there, movement classes, all of different levels and different types. We've got some that are just lying down, some that are seated, some that are standing, you know, all different types of classes that meet all of our needs, right? It's very, very adaptable and you can personalize it to your needs. Within that community, we have subgroups. So we have a big community, and then within that we have things like the menopause group, we have the parenting group, we have the neurodivergent group, we have the ME and chronic fatigue group. So you can meet with like-minded zebras who are going through the same lived experiences as you. And then education, we have monthly live events where we have EDS experts come and speak to our members. And we've had some amazing guests come on over the years because, again, you know, we need education about how to manage our condition, which, you know, there wasn't one place where you could go and get all of that information. So the Zebra Club has been growing. It's a growing resource library of expert presentations. And now we have members all over the world. It's a beautiful, beautiful community. I've never seen people so supportive of each other as you get in the app. So yeah, it's a beautiful place.
I think community is one of the most important aspects of this, like pooling our resources. So basically like a collective.
Yes.
And that's something I've said we've needed. Like I found the community, but we need the experts. We need
it's easy to dismiss a person, but dismissing thousands and thousands of people with the same thing is a lot harder
Yes,
to do.
Correct.
absolutely. Yeah.
So I
You
have
know,
a question.
yes.
How does the built-in community of the Zebra Club app contribute to the healing and support of the members? Like additionally, like a second question, because we have all been in Facebook groups, and is there some kind of like moderation happening to make sure that it doesn't spiral into misinformation or?
Totally. Yeah, that's a really, really good question. Thank you for asking that. It's a really important point. So, myself, I have a team of ambassadors behind me as well who volunteer. They're members who wanted to give back and they volunteer. We work really hard to ensure that it's a positive experience because, yes, most of our members have been on Facebook groups where you don't always have a positive experience, let's face it. So it's a very empowering, safe space. It's very, very important that people feel safe. They're obviously sharing. But, we have community guidelines on there that we make sure people are aware of. We don't allow certain things like, for example, we don't allow people to share body parts, photographs of body parts, because some, bruises, things like that, because some people get triggered by looking at body parts, for example. Things like that. We make sure that the experience is really safe and it's supportive in other ways. So it's positive, but also the support that this community give to each other. If someone types in, hey guys, I'm having a bad day, I'm in a flare, or whatever it might be, they'll have, 30 responses of people saying, I hear you. I've got this. Have you tried this? Have you done, we obviously don't give medical advice. None of us are doctors. And again, that's another one of our rules is that we do not give medical advice. But if you're sharing your lived experience, it's so nice for people to feel, gosh, I'm not alone. There are other people who understand me. It's wonderful. So yeah, it's a big part of the healing journey. But yeah, moderation is a big part of what we do. Not that we have to do much, to be honest. They're such wonderful members, but we do have guidelines in place.
We appreciate that. Thank you. One of the hardest things about having an inherited connective tissue disorder is you don't really know people or meet people to have community with outside of maybe family members. So I think that was one of the most important things in my journey was finding people community. And I so appreciate that someone like you has made a space like that, because that's what our community needs globally. And until more providers or people in our communities are trained and willing also to help us, you're filling a very large gap in many people's experiences. And I know not just in the United States, people globally experience the lack of trained providers. So I think it's also really special. We should note, if you're not a patient and you're a provider listening, Jeannie has been educating healthcare professionals about hypermobility with the EDS Echo series for quite a while. So one, thank you for that. What are some common misconceptions that you encounter from providers, therapists, that sort of thing, that doctors that you're teaching in the Echo series, and how do you address those misinformation and misconception?
I think the biggest misconception, and hopefully, the IMM is changing that. Patients are always told, you've got hypermobility, so you need to strengthen, you need to get stronger, and again, that's coming from the doctors, right? That's coming from the people who diagnose them. So as therapists, as people working, physical therapists, movement therapists, Pilates teachers, whatever, we then assume, well, we need to jump straight in and do strength work. You're hypermobile. Let's give you some hand weights. Let's get you pulling on bands. Let's do whatever. And that is the worst thing we can do, because that's what causes a lot of the issues. Because as we've talked about earlier today, we're not ready to jump in for strength work. If I haven't got my joints in the right place and I'm sitting like this, all rounded with a forward head posture and collapsed in on myself and hyperextended knees and all of those things, how can I start strengthening my shoulders when my shoulders aren't even in the right place? And that comes down to proprioception as well. So the biggest misconception is actually educating them that let's step back. Can we please go back to the breath work and the relaxation? That stuff's important too. Of course, we want to strengthen. I'm not saying don't do it. Of course, we need to do it. The more muscle tone we have, the more stable our joints are going to be. So it's really important. But you've got to do some things first before you get to the strength training. Okay, so yeah.
It's like, those really nice pools that have the gradual
beach entry.
The beach entry. We need the beach entry pool. We don't need to be jumping in the 12-foot.
Yes, exactly.
But what if you're impulsive?
Spontaneity. But so what are your personal aspirations for advancing awareness and treatment of hypermobility and our related conditions in the coming years? Where do you see this going?
Gosh, wow.
That's a big question.
It's a very big question. I want to, through the Zebra Club, to continue to reach as many people as need our help as possible. We're just working on new technology. So the Zebra Club is, it started in 2019 as a web app. It was just a web app. And then it became a mobile and a web app in 2021. And now we're just updating the technology again. And it's going to have a lot of new cool features that our community have been asking for. So the Zebra Club is growing. We're investing into the Zebra Club to make it even better. And I want to continue to help as many people as possible. Notwithstanding that, I will continue to provide free resources on my YouTube channel as well. So I want to support everyone as best I can. So yeah, onwards and upwards with the Zebra Club, really. Continuing to educate. I say we've just booked the next 2 IMM programs for the EDS Echo program. So those will be continuing. And with the new book coming out as well, again, hopefully that's going to reach more practitioners as well. So yeah, lots in the pipeline to continue spreading that awareness and, advocacy and making sure accurate information is getting out there is really, really important to me as well. So I continue to advocate on social media.
Of course, bringing the awareness and bringing accurate information is highly important to those of us like you who experience very late in life diagnosis. And it's insane to me that our average age of diagnosis is middle-aged for something that we're born with. And most of us started experiencing great difficulty in childhood, pre-adolescence, adolescence. There was new research published in April last month by Dr. Lee and Dr. Chopra that said that 95% of HEDS patients were misdiagnosed first with a psychiatric disorder, and many of them were diagnosed with things like conversion disorder, factitious disorder, Munchausen. Basically being told as patients, you're crazy, we don't see anything wrong with you. What changes would you like to see in how the medical system screens and supports hypermobile patients to close the gap of age of diagnosis?
Gosh, yeah. You just saying that just reminded me of, I've just finished my master's in pain management and my dissertation was on, obviously, I wanted to research.
Congratulations.
Yeah. Thank you. Again, I was drawn to that because our patients are in pain, right? So I wanted to learn more. But my dissertation was actually looking at the contributing factors to pain-related disability and reduced quality of life in EDS patients. And I wanted to try and isolate that into whether or how the medical system might have been contributing to that. And sadly, the medical system, it was a literature review and I had to go through, 20, 30 papers and analyze those. And the research is out there that, yes, the medical system sadly has a long way to go. And these are not all old papers. These were recent papers. Things are still not changing. And, one thing that we really, really have to do to help reduce the diagnosis delays is to change the education at the root level. So at medical school, at physiotherapy school, because I don't believe it's being, maybe there's 1 or 2 places now that do it, who might have certain universities, but in general, people aren't learning about this. So people are coming out of med school and they have one sort of slide on connective tissue disorders. So that's why we're still getting these diagnoses or misdiagnoses, because people don't even know to look for EDS.
Yeah.
It's just crazy. Just yesterday, I did a post yesterday about POTS, and somebody came back to me and said, well, POTS is a learned experience and you've got white coat syndrome. And I was like, well, no. But you just think this is why we have to keep doing this, because you've got people out there who say these ridiculous things.
I've just looked at a medical textbook for MDs, and it was like this much information about the inherited connective tissue disorders, very little of nothing about heads. Even if you do delve deeper in some specialties that would deal with us, it might be more information, but it's really never the complete information or complete picture. And I read medical research for fun. So what
That's
you
like
did
in court orders,
right? Like what you did for your dissertation, where you were looking for
Yes.
particular literature review. I read everything related to what all our diagnoses are.
Yes.
And I am continually astounded by how small the cohort or participant research sizes are. While there are several ongoing, very large research studies, thank goodness.
Yes.
But many of the articles on which we are basing our information upon as medical providers is very narrow in what we've looked at, particularly contributing to certain stereotypes that providers have. They generally tend to believe, anecdotally, that PEDS patients are all tall, thin, white women.
Yes.
And
skinny.
and medicine in general discounts pain of Black women. Looking at this intersectionally, we're looking at disability, a narrow disability, in a very narrow way. And we're not really giving adequate research, number one. So thank goodness for the EDS Society that's pushing some of this forward. But we, the medical community, could do a much better job of, one, starting with the medical research, delving deeper into better understanding these things with a more intersectional cohort. And then also, what are we teaching our future doctors, therapists, specialists that encounter us? And also teaching the approach that you have is being integrative, is not taught in medical school. We're very narrow in our specialties and our approaches. And even within rheumatology, so few rheumatologists will deal with us.
My rheumatologist was like, oh, you got that? Okay, bye.
So it's like geneticists too. Like,
aren't you the person?
Yes. So the wider education will also increase access to care.
Yes.
In the meantime, thank goodness we have resources like the Zebra Club, the EDS Society, that sort of thing, because we truly don't have good resources. It's so exciting to hear that we have an evidence-backed resource now.
Thank you for being reflecting on your journey. You've already shared so many of your lessons with us that you've learned about being resilient and adapting in the face of like chronic conditions. But do you have any other tidbits we might not have heard yet about being adaptable, or was it like just how do you okay, so I'm going to use myself as an example.
Sure.
I remember I emailed you before I had my hip surgery, and I was like, I really want to be slow and intentional and da-da-da-da. And then you didn't hear from me again because I just went and did whatever I was going to do. And I did it with a PT. I've recovered fine. And I'm getting ready to have the left one done, actually, in a little over a month. And even though I healed fine when I kind of just did it Shelli's way, I think I did mess up my back during that because I just ended up having to get some x-ray guided pain meds in my back to deal with that. So I promise, and this is on the podcast, I'm going to be better this time. And I'm not, I don't know, who won't I yell at? I won't yell at you guys if you will. My husband tries to hold me accountable. Like, okay,
along those same lines, like all of this was just kind of like not polished. It was a blah, blah, blah. So the problem I have, and I think this was the reason I had a delay in my diagnosis, I have so much here, and there's the gap in my expressive. I can't find the right words, right? I didn't realize that so many of my sensations in my body, now granted, I'm more connected to my body now than I was then, was actually like symptoms of orthostatic hypotension. But the only way that I described it to people, it came out as anxiety. And I couldn't actually discern if it was anxiety or until I actually had a tilt table test. And they actually put me in that situation. And I was like, oh, this is what it is.
Yeah, totally agree with you. When I was very, very ill, the trauma I talked about earlier, I kept going to my doctor and they just kept saying, oh, this is normal for a woman of your age. This is normal. How many times I went to the doctors and they were like, no, this is just normal. And it wasn't normal. But so I totally understand where you're coming from. I think the only thing we can do in situations like that, and I tell my clients the same thing, is print out, go on, I've got tons of blogs on my website that are researched, print out things from the EDS Society, print out, EDS Society is obviously a recognized resource, right? Trusted resources, and take them with you to your appointments and say, look, here are the symptoms of whatever it might be. And I'm having all of these. And then it's not just your word against theirs. You're saying, look, here's the evidence. These symptoms do manifest when you've got this condition, whatever it is you're dealing with. And then they have got to take you a little bit more seriously, I would hope. But when it's our word against theirs, it's so difficult, right? It's so easy to be gaslit. And I know so many of us have gone through that. It's horrid.
So many of us have medicalized trauma from
work in progress.
I found, even I go in with my binder and my diagnosis from a respected geneticist and medical studies, and I still will go into a doctor and they'll say, I'm not familiar with this. Let me look into it. And then they'll say, oh, well, I'm not comfortable prescribing, let's say, the meds for MCAS. And then we search the directory or ask in local groups and try to find a specialist that, do they know about how to manage us? Will they prescribe this? So we also, not only do we have the trauma of misdiagnosis, being gaslit, but then we have the trauma of we have to be as educated as physicians. We have to be able to navigate reading medical references. We have to navigate the executive dysfunction that many of us experience, being neurodivergent or chronically tired or in pain, of gathering all those things, getting all of our ducks in a row, being prepared, and then still fighting a system, and then fight your system when you have to. Here in the States, we have to file with insurance. So a lot of the things that are treatments or medications aren't covered because research isn't done on us. So the insurance company is going to say, well, that's off label.
I did my crutches initially after my surgery.
That's crazy.
I think there's a gap, so I asked providers that I am familiar with in the movement and physical medicine space. I said, hey, I'm talking to Jeannie Di Bon, who's an expert in this. What questions do you have? What do you want to ask her as a provider? And so we have several questions. These are from working providers. I'm going to read the first one. Dr. Chambavishi in New Jersey in the US asks, I struggle with what kind of weightlifting or strength training I can have my patients do, and if there's any standard advice I can give them. Does Jeannie know any material where people are pantomiming, so showing the angles or anything like that? Or are you doing them even in your videos or that sort of thing? Because he says he has to dig through all the material. Is there an easy resource to sign that? He's struggling to find the balance on giving people proper strength conditioning.
So he doesn't want to overwhelm.
And I would love for them to do things that are not explicitly just for posture, but like how to give us a resource for like the sake.
Yeah. We have whole programs in the Zebra Club which are with weights. as well. Obviously not one size fits all, so everyone's individual. And before we prescribe the weights and, weight training and hand weights and things to our patients, we need to make sure that we've done all the other steps first that we talked about earlier. I wouldn't want them going and just telling their patients to start doing weights until they've calmed the nervous system down, till they've understood some alignment, and they've worked on proprioception and control. Because once you add load into your workout, if you don't know how to control that extension of the joint, we're going to lose it. We're going to do all sorts of funny movements because we haven't learned the control. So all of those things, if we can get all of those things in place, then start introducing weights, etc. And as I say, yes, I've got lots and lots of examples on the Zebra Club for how to do that safely. But yeah, weights can be, weights are like, oh, we shouldn't be doing weights. But actually, I know a lot of people who do, serious weights and they've got EDS.
And I do. Yeah.
Yeah. There's nothing wrong with it.
Yeah. So you can get there. I will say I am a bit deconditioned comparatively, but at my strongest, I well outlift my own weight.
Yeah. Absolutely. If you've got good form.
That took time and safety.
Exactly.
And a big part of that was I did water cardio. So that offers a whole different experience, in terms of the water giving pressure. It affected my proprioception as well. And it strengthened all those little accessory muscles that I had skipped doing big weightlifting. So I learned that lesson the hard way because I was a weightlifter. And I still was having joint weakness and instability. Right? And the specialist was like, oh, well, you have these giant quads, but your little accessory muscles that are helping your hips stay stable or in your pelvis are all very weak.
Mm-hmm.
Yeah,
and,
exactly. And the
so
quads.
To the pain. So I had to go backwards. I learned the hard way also. In this whole time, I think I've been in and out of physical therapy since I was a young teenager. And currently my daughter has the very good luck of having a primary care doctor who knew nothing about EDS but researched. And she found there is a physical medicine practice near where we live that is not just treating kids that have had injuries. So it's not just sports medicine based. And they specialize their practice that specializes in disabled children. So and they serve a lot of autistic children as well. So they had some questions. So this is from Special Kids in Tennessee. They had a question about muscle endurance. So in physical therapy, when thinking about exercise prescription, which is what you were talking about, the reps and that sort of thing, they learn low weight, high reps is what they're taught. And then you work on muscular endurance, and then you can go to high weight, low reps. So, and work on isolated muscular strength. So that's what they're being taught. Is one tactic more beneficial and effective in muscle strengthening for patients with EDS once we get to that point? Do we go low, high or high, low?
Yeah. So this is a really interesting question because there was a research study probably a couple of years ago focused on the shoulders, and it was called high load. You might have read it, high load strengthening for the shoulders. And it was a randomized controlled trial. And at the end of the study, even though the patients had adverse effects, so a lot of people felt worse, a lot of people had headaches, etc., the conclusion was that high load strengthening was beneficial over low load strengthening for hypermobile EDS patients. And I was a little bit, I'm not sure about that. A year later, they did a follow-up. Thank goodness they did a follow-up because the results were actually there is no difference between high loading and low loading for the patients. So basically, there was no difference. You had the same outcomes whether you did high load resistance work for the shoulders or low load resistance work for the shoulders. So I think that's really key because, again, it's because of how we are, there isn't going to be one size that fits all. So I can't say definitely do high reps, low load, because that just wouldn't be true. Because that might work for one person, it would be horrible for another person. So I think it comes down to the individual. Me personally, and how I work with my clients is we always start with low load, low reps. So I'm kind of, again, turning everything on its head, because I don't want my patients having any kind of adverse effects. I don't want them feeling worse or having headaches or subluxations, right? So I'm going low load, low reps, and then I build that up very, very gradually. Yeah. Remember, we're not like non-EDS patients. We don't like to work to the point of fatigue. A lot of this stuff is let's work you until your muscles are fatigued. That's not going to work for us. That's going to cause a massive, massive flare up. So I go low load, low reps, and then I build them up together gradually, which probably is totally turning everything on its head. But it's what I found works for EDS patients.
So the answer is neither, but both.
Exactly.
So really, well, and then based on that patient's experience and maybe experimenting with them,
Yes.
you can gradually move to one of those
Exactly.
increasing options. That's the goal, is muscle endurance and strength.
Exactly.
Eventually, but carefully. We don't want to spiral into a migraine or flares or etc.
Yeah, because if you start high load, but you haven't taught that person alignment or how to actually ensure they're in the right place, you're going to give them high load, everything's going to fall out, right? We're going to have a big problem. And if you go the other way, even if it's low load, but you do high reps, but they haven't built their tissue tolerance, which we talked about earlier, you could have a massive flare up as well. So safest way, and if you want to build proper endurance and safe stability, we're going to go low load, low reps, and we're going to build it up from there.
So the prescription is low, low, slow, slow.
Yeah, exactly.
And then we should hopefully have built our body safety, and we can work with the patient to determine how we're going to experiment as we go. So another big question they had was about impact. And I actually got multiple questions about this, so I only kept the one. Patients with EDS are typically advised to stick with low impact aerobic exercises. So in their training, they're taught to tell hypermobile patients walking, swimming, biking. So if they have a patient that has been safely implementing a steady and appropriate exercise program, and they've built endurance and stability and muscle strength, is there ever a time that more challenge can be brought in and the patient can work with higher impact? If that's appropriate, or will these type of exercises always just be deemed as damaging?
Not necessarily, no. Again, it's going to come down to the individual, of course. You know, in the Zebra Club, we have cardio classes. We have, because the members love it. Do you remember step classes? You remember the aerobics?
I like that class.
So I've done Zumba and I could do it.
Yeah.
I did cheer and dance. So I'm all about doing the routine.
Yeah. So we do step classes in the Zebra Club. I love step classes. You've got a reformer. Sometimes we put the jump board on me personally, this is the jump board on the reformer, and I'm jumping on the reformer.
I have a jump board.
Yeah. So again, the same things apply, right? The thing with hypermobility is we've got joint laxity, right? We know that. And our tissues are often deconditioned. We need to build elasticity in the tissues. And that's, with the healthy fascia, the tensegrity, this expansive quality of the tissue. If we can build elasticity, and that person can tolerate it, I don't like to be the person who says, no, you can never do that. Because what do we know?
Someone like me is going to be like, oh, watch me do this now.
Exactly. So again, if you decided, I know I'm going to try whatever it might be, you start low and you go slow. So don't say, I'm going to go and do, I can't think of something, but I don't know, an hour's class of this high impact thing, whatever it is. You might do it for 5 minutes and see how you feel and go, actually, I feel all right. That was okay. And then maybe I'll do 10 minutes and I'll build it up that way. But I don't want to say to people, no, never, ever do these things, because that's not right either.
And it also depends on the person.
Exactly.
Not all EDS types have the same experiences. And even with heads, we have different experiences. In some types of EDS I have very severe hip dysplasia. So when I ran, I very much damaged my connective tissue.
Maybe that's where my
hip.
tears came from.
Yeah. And eventually I found a very renowned hip orthopedist. And I said, one of my goals and what I defined as strength is because you see these things in media or whatever. And so you think, okay, my goal is to run a marathon. My goal is to run. That's my pinnacle of peak health and endurance. And I played sports as a kid. And so we have these, of what strength is that we have to challenge as well, but then also take into account for different patients. Not all of us have, a skeletal deformity like hip dysplasia that compounds the issue. And so it is, it's about determining slowly, but also taking into context that patient's
absolutely,
actual condition.
But if they don't have a diagnosis,
if they don't, and that's why diagnosis is so important. And to, I was seeing a hip specialist before. That's how I got diagnosed. So, when they were giving me the advice was good advice, but that was before I was an EDS patient.
Of course.
The other big question that we get is about hyperextension and working. How do we work through that? So the last question that they had is, if hypermobility is the norm for a patient with EDS, is it still considered unsafe to work with our natural joint and range of motion, or should we avoid what we call hyperextension, which is what I don't even know what normal is in some cases. Yes, that's the question.
Okay, I know I'm not taking it too far, but is this still too far? I don't know.
Yeah. Well, it's normal. That's the problem, isn't it? It's normal for us. So we don't, oftentimes we don't know that there's anything wrong with that, right? Because we've always done that.
So as professionals, their question is, do I teach them to avoid hyperextension, which would be teaching us normal range of motion and then stopping there as we in the movement?
Yes. So again, I'm probably going against the grain here, but
I swear that.
Yeah. So the problem with hyperextension is, unless you're a trained athlete, gymnast, dancer, where that can be quite beneficial, right? They go into these. They've been trained how to control that. Most of us, general population, we don't know how to control it. So I used to stand with my knees hyperextended, and I always had knee pain. I used to weight bear with my elbows hyperextended and all these horrible positions because I didn't know any different. I didn't know that that was wrong. So I didn't have any control. So I had to teach myself how to control that range. So now if I wanted to, I could go into that end of range, but I know how to do it safely. And I think that's the problem. That's the biggest issue. If I start people off and I reduce their range of motion to avoid hyperextension, okay, and I stop them because I want them to start working. The other problem with hyperextension is I can just fall into it. If I've got no control, I can just fall into it and my muscles no longer have to work. You don't have to work. You can just hang out in these joints, which isn't good for wear and tear. And your muscles are no longer working. They're just held in this lengthened position.
You're tearing your hips.
Yeah. And we need...
Just for little things throughout the day, I'll catch myself twisting my neck to look at something. I'm like, oh no, don't do that. I cannot stand without consciously telling my knees to not hyperextend. I still can't I can't go offline. It's very conscious effort to stand properly.
It's you've got to learn. We come back to sensation. We have to find what is the sensation when I'm not hyperextending. And that's hard. Because if you've done it your whole life, let's face it, most of us have done it since we were children. So that's a really ingrained movement pattern.
It's like completely unconscious habit, right?
Totally.
So we're reteaching ourselves. And I've had this question from multiple listeners, multiple viewers on my socials, and from doctors. Is there a place or resource that shows in what
side by
place,
side each thing. Like if you're doing this exercise,
what the normal range of
Yes.
motion is for the joints.
I've got-
where do they find that?
Well, actually, on my YouTube channel, I've done a couple of videos recently on exactly these topics because I'm demonstrating, look what happens when we do this compared to how it should be. Same with the knees, same with the feet, same with the pelvis, the low back. So yeah, if they head to my YouTube channel, they'll find videos on that. Because yeah, it's really helpful, isn't it, to see that's what it should look like, but mine look like this.
Our YouTube has mostly just been a few shorts I've uploaded and like podcast episodes, but we're trying to do some more content there.
Yeah.
That would
Share
be,
the resource.
Yeah, share the resources. Because like she said, we
Totally.
get asked this question all the time, but we haven't put anything out on our YouTube where we could actually be linked to your YouTube.
That's not within our scope. Like we're patients. I want to show you the proper way. I want to say, okay, here's the resource.
Yeah, because I'm not trying
Let me point you to that.
I will
Yeah.
teach you how to find financial fraud. I'm qualified to do that, but not bendy stuff. No.
So what general advice would you give to healthcare professionals with hypermobile patients? What's the most important thing that they should know as they embark on caring for us?
Do you know what the most important thing, and it's one of the things I convey to the attendees on my courses, is that as we're movement professionals or physiotherapists, physical therapists, we feel like patients need to do a lot, right? They come to see us, so we have to give them lots of things to do. Oh, do this exercise, do this, go home with a big sheet of exercises. Actually, less is more with hypermobility. So when people come to see me, sometimes, we spend a lot of time talking the first lesson because I really want to understand them.
Like
actually listening to them. And B, we might spend some time on the table doing some breath work and helping them start to calm their nervous system down. And that's all they have to take away with them. But I think sometimes as movement professionals, we're like, oh, I didn't give them 20 exercises to take home. That's too much for us. We get overloaded physically and cognitively. Keep it simple. Honestly, the patients will be so happy that you've listened and you haven't given them a ton of things to do that they can't do. You know, I think it'll be a huge game changer for people. So yeah, go slow with these patients. They don't need to be rushed.
It's a very mindful and intentional practice.
Yes.
I think is where we need to kind of recenter our experiences from our own experience in, just as a patient, but also what you're advising our providers to do.
Yes.
So remind us again, when is the book coming out?
Do you have a date?
Again, the publisher has a date of November, and that obviously that's not in my hands, but let's say November, December, certainly by the end of the year.
Holiday time.
Yes.
Yes.
Stocking stuffer.
You mentioned the upcoming EDS Echo series. Is that published and available yet? So we can share that in the show notes as well for our providers.
So yes, our next course is in September. That's already fully booked and subscribed. So, but there is a wait list just in case anyone needs to change. The next course will be it seems ages away, but it will come around quickly, January 2026. Which
so you guys doing those about quarterly then, or
we do them twice a year? They're 9 weeks long, 2 hours a week. So it's 18 hours of content, education, plus in order to be certified and go on my IMM directory, which is on my website, they have to complete an 8-week client plan. So they go away and they have a couple of months to actually do a case study and actually demonstrate they understand the IMM. So it's quite a rigorous course. It's not just attending. You've actually got to do some work as well.
You have to want to.
So there's full application documentation.
Yes,
Very
exactly.
exciting. So you kind of glossed over it. So there was another resource you mentioned. So for patients who are looking for a provider that is trained in your approach, the IMM, where do we go again?
So if you head to my website, under clinics, there is a tab called IMM directory, and that is a global directory. And that that list is growing as we obviously qualify new people. But yeah, quite a lot of people, a big portion come from the US. So it's great that we have so many providers in the US who want to learn about this. So yeah, lots of people in the US, but also Australia, UK, Europe, all over the world. So take a look at that.
Well, I'm so excited. Thank you for sharing your resources.
Yeah.
Thank you for joining us today to have this
Yeah,
conversation.
thank you for your time.
Oh, thank you. It's been wonderful.
It really means a lot to us to, be able to ask questions, be able to ask questions of people that listen or watch, and share these resources to get the word out to people that there are places we can go for help. It may be virtual, it may be an app, it may be a book, but there are people who are like you that care deeply and have created community and resources for us to
Thank
share
you.
within the patient community and also the providers that care for us.
Thank you very much.
Can't thank you enough for all the work that you do.
My pleasure. And thank you for inviting me on today. I've really enjoyed chatting with you. Thank you.
Same.
Thank you for sharing your story with us.